Well, welcome everyone to the EKG case for the week of October 22nd, 2012. This is Amol Matu at University of Maryland. This week's case was sent to me by Dr. Elisha Targonsky, who is an attending emergency physician at Credit Valley Hospital in Ontario, just outside of Toronto. And he had sent this case. It was an interesting case that he saw. An elderly man had presented with pretty much a non-cardiopulmonary type of complaints. We're just going to focus not so much on the history, although that may become a little bit important as we talk about differentials a little bit later on. But in this particular case, the patient's presenting not really blowing your socks off in terms of worry by history of ACS. But then you get a 12-lead EKG, and I think it was for some type of pre-op evaluation perhaps, but for some reason he got a 12-lead EKG, and the EKG is kind of blowing your socks off because it's really, really concerning, right? What you're looking at on this 12-lead EKG, you've got a person who looks for all the world like he's having an acute anterior wall STEMI. There's no R waves in those precordial leads. You've got some fairly sizable Q waves out there, especially V4, V5, and some god-awful looking ST segment elevation in V4, V5, and probably some ST segment elevation in V3, maybe in V2 as well. So it sure as heck looks like he's having a big anterior wall STEMI, and he's already starting to develop Q waves. Now, fortunately, as I mentioned a couple of times, he wasn't complaining of significant cardiopulmonary complaints, but it gives us a great opportunity to talk about some of the EKG findings in this particular case. First thing you're always going to do when you see an abnormal EKG, you want to look for prior EKGs, and in this particular case, they couldn't find any. And so we'll move forward. We'll talk about different things that can produce ST segment elevation. We've briefly talked on this before, but you can never talk about ST segment elevation often enough as far as I'm concerned. So biggest thing we always worry about, of course, is an ST elevation, myocardial infarction, but there's a lot of other things that give you ST elevation, right? Pericarditis and myocarditis, early repolarization, and then some of the other annoying things like LVH, which is probably the biggest and toughest mimic that we've got. Left bundle, aneurysm, hyperkalemia, the syphilis of electrocardiography. It can do anything to the 12-lead. And although we haven't talked about it before, you could also classify CNS effects and also even myocarditis as syphilitic, because they can do a lot of different things to the 12-lead EKG as well, and also Brugada syndrome. For those people that might be new to the EKG videos, by the way, if you don't have any idea what I'm talking about with regards to syphilis and electrocardiography, well, you just need to go back a few weeks and you'll learn how syphilis relates to electrocardiography. Go figure. So anyway, that's a pretty good differential for ST elevation on the 12-lead. There might be a few other things as well, but these are the things that certainly jumped to our mind initially. And going back to this 12-lead EKG, we can start knocking out some of the things from this differential. Is there voltage criteria for left ventricular hypertrophy? Well, there are some big QRS complexes, but the two criteria that I learned, you look for an R wave in AVL greater than 11 millimeters, and that's not there. You look for big S waves in V1 and V2. So there's the S wave in V1, V2. You take the bigger S wave in V1, V2 and add it to the bigger R wave in V5, V6. And if that's greater than 35, then that's LVH. And it does not appear that that's the case. So we can probably take LVH off our list of possibilities. There's no evidence of a left bundle, right? There's not a wide QRS complex, so we can get rid of a left bundle. There's a PVC. We're going to ignore that. That's the only wide complex beat that we've got. Hyperkalemia, we could probably get rid of hyperkalemia as well. I'm not seeing peak T waves, and there's no widening of the QRS that you would typically see with hyperkalemia, so we can probably get rid of hyperkalemia also. By history, let's get rid of CNS problems. People who have nasty EKGs from CNS effects usually have an altered level of consciousness, so we can get rid of that. And then I think we can probably fairly get rid of Brugada syndrome as well, because you don't have an incomplete or complete right bundle pattern in V1 and V2. and you'd expect to see that with the right bundle. So let's go ahead and get rid of some of these things. So we're going to get rid of LVH. There's no voltage criteria. The other thing I didn't mention, with LVH, you really should not expect to see Q waves. That's not typical for LVH, so that's another reason we can get rid of LVH. We've gotten rid of left bundle, hyperkalemia, CNS, Brugada. And so that leaves us with a smaller differential, and I like narrowing down the differential like this. So that still leaves us with some concerning things. Next, let's talk about some of these. Is there evidence of pericarditis, myocarditis, or benign early repolarization? Well, taking a look at that 12-lead EKG once again. Remember what we've talked about before. With pericarditis and benign early repol, the ST segment elevation should be diffuse and should always be concave upwards. If you ever have horizontal or tombstone type of ST segment elevation, you just ruled out pericarditis and early repolarization. And what I would suggest to you is that there's some horizontal ST segments right up there, and probably there as well, and there. This is not the typical concave upwards ST segment elevation that we probably should see with pericarditis and early repol. And also you should not typically see gigantic Q waves with pericarditis and early repol, so let's get rid of those. And myocarditis also should not generally give you gigantic Q waves. And so based on some of those ST segment morphologic abnormalities and the Q waves, we're going to get rid of a few of those things. And also there's no PR depression, and so that knocks down our concern for pericarditis, or at least viral pericarditis. It gets rid of that. So we've gotten rid of pericarditis, myocarditis, benign early repol. It's nice how we're narrowing this list based on some simple things. And that leaves us with two possibilities: ST segment elevation MI and ventricular aneurysm. So going back up here, well, in many respects, this could be either one. And if the patient had some type of cardiopulmonary complaint, then you definitely would have to worry a lot more about STEMI in this particular case. But how do you distinguish between STEMI versus true ventricular aneurysm? There's a few clues. First of all, STEMI ought to give you some concerning signs and symptoms. Aneurysm, if you're lucky, these patients will not present with concerning signs or symptoms. There's a few other helpful clues as well. If you get serial EKGs, and I'm going to put this slide up here right now, when in doubt, you always get serial EKGs. We've emphasized that many times before on the EKG videocast. Get serial EKGs. Remember, how much does an EKG cost? Practically nothing. It's a piece of paper and ink. So when in doubt, don't be cheap. Get some serial EKGs, and that can be very helpful. With the true STEMI, you'll probably, not always, but probably see some evolving changes over the next 15, 20, 30 minutes, over an hour. So be liberal about getting serial EKGs. With the aneurysm, you really should not see evolving changes. With an ST segment elevation, you may or may not see Q waves, whereas with the ventricular aneurysm, there are always Q waves. You pretty much will not develop a ventricular aneurysm unless you have Q waves from a previous transmural, also previously known as a Q wave MI, transmural MI. Aneurysms are pretty much only going to form with big MIs, and so an aneurysm is always going to be associated with Q waves. If you have an early STEMI, you may not see Q waves. So if you see Q waves, it doesn't rule in or out anything, but if you don't see Q waves, you just ruled out a ventricular aneurysm. So that's helpful as well. With the ventricular aneurysm, you really should not see reciprocal changes, and that's another helpful clue. With the STEMI, you oftentimes do. Not always, but you often do. So if you see reciprocal changes, you just ruled out an aneurysm. All right? So there's some helpful clues that I'll summarize once again. Concerning signs or symptoms, go with STEMI. If you see evolving changes, go with STEMI. If you don't see Q waves, go with STEMI. If you see reciprocal changes, go with STEMI. And if you get an old EKG which looks different, go with STEMI. If the old EKG does not look any different, then it's probably the aneurysm. And of course, hopefully to call it an aneurysm, you're going to see big Q waves and definitely no reciprocal changes. If you don't come up with an answer, even with all of these clues, then you're left with some other miscellaneous techniques. Get serial troponins, get an echo, call cardiology. Sometimes they might even be willing to take these patients to the cath lab. All right. So there's some very nice clues there. And when we look back at, actually, let me go back to the EKG here. When we look back at this original EKG, there's some things that are helpful. Notice you definitely have Q waves. And so that can be either one. So that's not all that helpful. If we didn't see Q waves, we definitely call this a STEMI. All right, what else? Notice that there's no reciprocal changes. You've got concerning ST elevation here, but you don't have any reciprocal ST depression anywhere. And that is a bit more suggestive of the aneurysm. And if you got serial EKGs, you would not see this one evolve, because this it turned out to be a ventricular aneurysm. Let me show you a few more aneurysms just to really nail this home. And these are scary looking EKGs. These are patients that come in with non-cardiopulmonary complaints and scary EKGs. Here's a nice aneurysm that I took care of. Notice the big Q waves and no reciprocal changes. Next example. Notice once again, there's big Q waves up there and no reciprocal changes. Here's another example. Once again, gigantic Q waves and no reciprocal changes. Okay, and one more example: giant Q wave, big Q waves, not just little Q waves, but some of these leads have pretty big Q waves, and once again, no reciprocal changes. All right, so look for that. And when you see giant Q waves and no reciprocal changes, at the very least, you've got to think about an aneurysm. Now, Dr. Targonsky actually put together a very nice PowerPoint presentation on this particular topic, and he was kind enough to send me the PowerPoints and allow me to use the content and some of the images that he had in addition to the EKG. So this slide he actually created, although it's on my slide background. There's a few other important points that he wanted to make about an aneurysm that I'm going to share with you all. So first of all, generally speaking, the aneurysm is going to form a couple of weeks after the MI. Usually it's in the anterior leads. Rarely you may see an inferior wall aneurysm. Almost always, in all the examples I've shown you, these are anterior wall aneurysms. It's due to scar formation. You can get paradoxical wall movement, and typical causes post-MI, cardiomyopathy, infections, congenital, and so on. And I guess this is what the aneurysm looks like. Although this actually looks like a really, really scary Halloween mask, almost. We got Halloween coming up here in the United States, so I'm thinking about what type of mask to wear. I'm going to see if I can go to a local store and get a ventricular aneurysm mask for Halloween. That's pretty scary looking, if that's what it really looks like. Clinical significance of an aneurysm: you can get poor ejection fraction, CHF, cardiomyopathies, you can get arrhythmias, you can get death, the worst complication of all, and also embolization. Don't forget, because you've got this aneurysm that's not beating, you can get clots forming in there, and typically these patients need to be on anticoagulation. Take-home points: remember, key point here, key point for the EKG series, the EKG point that we'll leave with: not everything that produces ST elevation is MI or pericarditis. There's a bunch of things that produce ST segment elevation, but with some very simple reasoning, you can narrow that differential. Hopefully, we're able to demonstrate that for you. If you can't explain the ST elevation, get serial troponins, get a stat echo, get cardiology involved. And also remember that these patients do have risk for arrhythmia and also embolization. So my thanks to Dr. Alicia Targonsky for putting together a great PowerPoint presentation, sharing those slides, sharing a great EKG, and I'm sure the presentation that he gave back home to his own students and residents must have been fantastic. Again, thank you so much for sharing a great case with us. Hopefully that case was helpful, and I look forward to talking to all of you next week. Bye for now.